Hey, everybody, it's Kevin and Bruce from the RPH Ally world. We're so excited to be here. I'm always excited to talk with Bruce, one of my close friends in pharmacy, to keep us kind of on our toes when it comes to lots of things. And he actually had an uncomfortable speech that he wrote. I'd love to be able to tell you guys more about it right after we run the reel here. But Florida Pharmacists Association, thank you for having Bruce. Huge and genius decision to bring him on board. And you'll get to hear from him in just 5 seconds. All right, Bruce. So congratulations on the, delivering another, I'm sure, incredible keynote speech on a difficult subject. Can you tell us more, Bruce? Why was it difficult to deliver it? Like, why was it something that gave you angst?
I think because if you know me really well, you know that I focus on how to talk with patients, motivational interviewing and those things. It's not that this was completely outside of my comfort zone. It's just that the topic of humanizing the workplace, and I talked in specific about why it matters. The impact on the healthcare professional. It was difficult because I don't like pointing fingers and blaming people as a way of solving problems. And so I have my own personal feelings about this, and I wanted to be as objective as possible. And so I did as much reading as and went through the literature as much as I could to formulate the talk. And so that's why I agonized a little bit. Like I said, I wanted to be objective and fair.
Bruce, I love that you say that, because not only do I know you want to be objective and fair, I know you cared about it not just being lip service and not just having two sides of opposing each other, but actually making real progress for our patients. That's one thing that I love, having that end goal in place, wanting it to do something and be meaningful. So tell us a little more about it, Bruce. Like, why is humanizing, pharmacy, humanizing the workplace for our world so important, and how did we go astray?
Well, I'll give you kind of the 5-minute overview of the talk, basically. What I started with was a very simple but profoundly important proposition. We're human beings. We have certain emotional and psychological needs for support that when they go away, it harms us. I mean, we have a need for a sense of well-being. We have a need for accomplishment. We have a need to feel like we're doing things that are meaningful. We have a need to feel safe. We have a need to feel appreciated. And I listen, and we have a need for growth and creativity. And I listen to people talk about work-life balance. And it kind of drives me a little bit crazy, because the fact is, we're a human being in relation, no matter what environment we're in. We are hardwired to need relationships, and we need relationships, whether we're at home or whether at work, that support those emotional and psychological needs. So, I prefer to call it work-life alignment. The fact of the matter is, if I'm having real struggles at home, it's going to affect me at work. If I'm having real struggles at work, it's going to affect me at home. My brain, it gets carried around with me and experiences stress and those things no matter where I am. They're not separate. And so I wanted to first establish, what do human beings need, regardless of where they are. And then I wanted to talk about the difference between acute and chronic stress and why it's important. Acute stress is, I got an interview coming up. I really want to do well so I can get this job. And the difference is, though, that stress is going to go away.
Right.
Chronic stress doesn't go away. And our brains are wired as such that the primary function of our brain, more than anything else, is to keep us safe, is to protect the organism, to help us survive. When we have chronic stress and and our brain is constantly saying to us, danger, Will Robinson, right? That is just not healthy for us. And we have chronic stress when our fundamental human needs are not being met. That's the important part. It doesn't matter where it is. Okay. And so
Wow.
the other thing that happens when people, the sad thing that happens when people are chronically stressed, especially at work, they take it on. They often say things to themselves like, I should be better at this. I told the story of, there was a young pharmacist who was working for a chain, and he put a post on LinkedIn, and that post was about, the start of the post was, being a pharmacist is really stressful. Being a pharmacy manager is really stressful. I don't think it ever occurred to him that that it doesn't have to be that way. I think he had accepted that this is his life, and part of the problem was he just wasn't used to it. That's the real danger. Our brain is telling us by way of stress, this is not good for us. And we're trying to compensate by saying there must be something wrong with me. He then went on to say that his staff and him set a new record in filling 459 prescriptions in one day. And he had this poster board up that had an arrow pointing to that target because they wanted to beat that. And offline, Kevin, because I didn't want him to think I was attacking him, I asked him the question offline in a private LinkedIn message.
Yeah.
Those 459 prescriptions represent human beings. What percent of those prescriptions were new prescriptions for a chronic illness? And what percent of those people did you talk to?
Mm-hmm.
Because I said, right now, your goal seems to be how many you can dispense. And there's a patient at the other end. He hasn't answered my question. It's been 4 weeks, by the way. By the way, one of the vice presidents for that organization, and I won't say which, responded to him by saying, sounds like you're doing well. Don't worry, you'll get used to it. And that's the overriding message pharmacists keep hearing, as if the problem is us. When you combine a job that has high demand and low control meaning any healthy work environment should be giving me the opportunity to have a say, to have my say heard, to have some direct profiting from the revenues of the organization. Okay. When you have a situation with high demand and low control, which is what we have when staffing is based upon how many prescriptions are dispensed per hour and how many immunizations you do per hour, you have a situation that not only sets up psychological and emotional health, but the research says that if you've got 4 quadrants, and one axis is low to high demand and the other axis is low to high control, and you're in that quadrant with high demand, low control, you are 4 times as likely to have cardiovascular disease. So, this is why this is important. And I'll say one other thing and then I'll shut up and let you ask or talk. Burnout and chronic illness or chronic stress and people leaving their jobs in healthcare are at an all-time record high. They have not come down since COVID. Okay. Good friend of mine, Jim Farrell. Jim Farrell wrote the book Leadership and Self-Deception and started the Arbinger Institute. He's now formed his new organization. He's an internationally known Fortune 500 company consultant. He said every organization, every industry that he deals with is moving away from a post-World War II mentality. And that mentality is, let's make money for the stockholders and the C-suite employees. And they're moving away from that to, we have got to take care of our workers psychologically, emotionally, give them better pensions, because turnover is killing us. Okay? One industry is moving in the other direction, healthcare. We think we make widgets now. And burnout, primary reasons, according to Harvard Business Review, that burnout occurs, three major reasons. A values mismatch occurs when your ethical and moral compass are in direct conflict with the ethical and moral compass of the organization. 2, a workload mismatch, meaning high demand, low control, and you're not even doing the thing that you were trained for, which in our case is taking care of patients. Okay. And 3, a control mismatch, when you don't have autonomy, when your work's decided for you already. So think about what we have. We have people who have taken an oath and have practice standards, whether it's pharmacy, nursing, or medicine, who have taken an oath and have practice standards that put the patient first, and yet the work environments they're being hired into are putting them farther and farther away from taking care of patients. They then have to wrestle with the moral and ethical dilemma of going home every day knowing that they've ignored the care of many patients. That creates burnout.
Here's my question, Bruce, inside of it that I haven't heard a lot of people talk about that I love. I've read some Jim things because you and I are connected, and I often see common Jim stuff, and I think I follow Jim now. Brilliant, lots of interesting things to kind of comment on in the workspace and kind of how we treat each other as human beings in general. But my question is this, Bruce. Identify for me an industry or a vocation that is doing it right. They have high stress, they have high demand, and this is the way they're going about it to be successful for their employees, for their patient, or for their clients.
Actually, I'll tell you about one in healthcare, ChenMed. I don't know if you've heard of them. Primary care physician group. They go completely at risk. I don't know if they've developed their own completely at-risk model, and the patient is everything. Every one of their physicians get motivational interviewing training because they have decided that it produces better outcomes for their patients. Another example, I'm very proud of it. The Ohio State University, I'm proud of it because I'm a grad 3 times. They have a complete on-campus program for all students and employees. Better foods to eat. They've expanded facilities for any faculty member to work out, any student to work out. They've made sure that that lunch breaks and the like are sufficiently long so that people can do it. They're seeing decrease in absenteeism, decrease in illness. So this is a campus-wide, every inch of campus application of creating a work environment in which people can opt to be healthy. Yeah, and the numbers are supporting it. Here's an interesting thing that just boggles my mind. We know that non-adherence is a huge problem. Non-adherence to medication regimens. The rate hasn't changed in 40 years, despite going from 4 times a day to once a day, once a week, once a month medication hasn't changed in 40 years. Costs associated with non-adherence, $500 billion. Why haven't any of the chains worked with schools or colleges of pharmacy to do demonstration projects to look at, and I'm not talking about every store. I understand you can't scale that immediately. So why not take a small group of stores, give them the appropriate staffing, get well-trained pharmacists who know how to talk to patients, and measure the impact on adherence and outcomes, because that's where the money really is.
Mm-hmm.
And I don't understand why. I don't even understand why many of the chains don't have automated dispensing equipment to free the pharmacists up. So, there just seems to me that there's a lot that can be done. And on the other hand, if they're not willing, then one of the parts of my talk was telling pharmacists things that we need to do. We need to be brave like Bled Tano and go to our legislators. We need to be brave like Randy McDonough. Randy McDonough is in Iowa. I think you know who he is. He's running for APHA president. And Randy went to the largest insurer in his state, and they did a demonstration project. He's an independent pharmacist. They did a demonstration project and showed a savings based upon what Randy is doing of $300 per member per month. And he's gone to the PBMs and gotten some PBM reform in Iowa. I guess what I'm saying, every single one of us, if we care about this profession, has got to, I don't know if you remember the movie Network. There was a line in the movie, I'm mad as hell and I'm not going to take it anymore. All of us have got to get to the point where we say, this is our profession. We set our standards. We have allowed organizations to set our standards. And it's wrong. It's just wrong.
Yeah, I'm really curious, Bruce, in lots of ways. I've become an incentives guy, try to find aligned incentives. I think it was the Charlie Munger line, right? That he talked about knowing what a business is going to do based on, do you show me what their incentives are? And so seeing that, I'm seeing so many healthcare professionals. Jenna Quinn and I were just talking the other day about this, what she's doing in the pediatric space. Jaron Stout and I were talking the other day about the long-term care space. Thea and I were talking about it. Same thing you're saying with Randy, of them saying, I'm tired of these incentives driving me to have to do these things that go against my moral compass. So therefore, I'm going to do something entirely different and show the value of it so I can get paid and reimbursed. Correct. I think that's an interesting place we're at right now, Bruce, when it comes to the incentives of the current models that are in play. Here's what they are, and do they align with us actually taking care of patients? That's my big concern.
I agree. And here is if there's ever been an incentive, does anybody out there honestly in your heart believe we are ever going to get provider status by dispensing medication? If that's all we do. And if all we do is dispense medication or dispense information, meaning there's a big difference between really working with a patient to understand what's causing them to not want to take a medicine or manage their disease. If information was enough, if information alone was enough, no healthcare professional would smoke or be overweight. If that's all it took, right? And so if we don't get that, and I know we've heard this before, but we're really at a critical point. If we don't get that, we're never going to get provider status by dispensing. And where AI is right now, I have asked ChatGPT some really complex questions about talking to patients who have opioid use disorder.
Mm-hmm.
It's amazing what can come out of it. And so we have got to do the kinds of things that Randy is talking about and rethink, who we are based upon our training.
Transactional has to become relational, right? I think that is the next step for just about every profession because of what we're seeing in terms of automation and things coming along the lines. And to be able to get the level of expertise necessary to connect those dots for patients, it isn't information exchange. It isn't product exchange. I mean, Bruce, a real thorn in my side, and you know me well enough that this is the case. I'm sick and tired of us always talking about how do we get medications into patients' hands? Yes, it's part of the problems. Guess what? Another part of the problem is getting medications into patients' hands because it's wrong. It's the wrong dose. We're on them too long. We're not monitoring them appropriately. All of those things are in place, and we need to change the system so that we're incentivizing for care and not for drugs being put into people's hands.
and look at DeLon Canterbury. DeLon has spent he's been spending the majority of his life in pharmacy, trying to get many seniors off of unnecessary medications. We got to get to the point where what we get compensated for is appropriate care, whether that means getting somebody off of med or getting them on a med.
You hit it. And I think that's the interesting thing, talking to, folks like DeLon and Donna Bartlett and Rajinder Rai. I mean, Rajinder being an owner of multiple pharmacies in the California area, she is really a proponent of saying, how can we change the reimbursement model so I'm getting a dispensing or administration fee that is paying for my clinical time? Like, my job should be taking care of the patient. My job and my payment should be attached to how well I'm caring for the patient. You mentioned Chen Med, some of the value-based, capitated, fully capitated or risk models.
Right.
I think it's an interesting space for pharmacy to be able to jump into and to see some of those, things come along the way. But here are the pieces I would say, Bruce, and I'd love to be able to hear your thoughts on what we need to do to make it from where we are today to the next steps. It is doing the things that we are currently able to do and get paid for in incident to paying models, or in those spaces that we're getting direct reimbursement for, and documenting like we've never documented before to show those gaps that we are closing and the costs that are changing based on what we are currently doing. Because we do not do that well enough. We have, not been trained to do that kind of documentation and provide that care in that setting. But if we want to take advantage of going from transactional to relational, that is a very necessary couple steps. Are there more, Bruce, that you feel like here are other things to get us from point A to point B where we really want to be?
I'm very biased about this. For the first time in history, by the way, the American Council on Pharmaceutical Education has made motivational interviewing a required accreditation standard. One of the reasons I'm so biased about MI is not because I've taught it for 35 years. It is evidence-based. Here we are in an evidence-based profession. We talk about evidence-based medicine. Why do we not talk about evidence-based communication? Why do we not talk about training people? I've listened to recorded conversations between healthcare professionals and patients, and it's often abysmal because we are not training people on how to have a conversation with the patient who says, I'm not sure I want to take it, and they need it, or I'll take the medicine, but don't expect me to go outside and sweat when it's hot outside, and have a conversation with that person. So, but my fear is we would never have anybody but a pharmacotherapy specialist teach antimicrobial therapy in a school of pharmacy. But we often ask anybody with a warm body to teach communication, and we tell them to go learn it. We have very few bona fide experts that really know how to do this, and it shows in the way we talk with patients. So that would be a biggie to me, and realize, look, there's been research that shows we need a minimum of 8 hours of training of motivational interviewing by an expert. And when we do, we produce substantially different numbers in terms of outcomes and the like. So I would add that. But we've also got to get certain groups on board. We've got to get state boards of pharmacy on board. We've got to ask pharmacists to start joining organizations like state and national associations. We can't expect numbers like 15% membership to give those organizations to have the resources they need to go to bat for us. But on the other hand, we also have got to tell those organizations like APHA and NCPA and ASHP, quit acting as if you're not working on the same problem. In other words, you are here to help the professional, the pharmacist. This is not a competition.
No. And you know that, Bruce. I mean, being such a wonderful advocate on the RPH Ally team, like, that's the whole point of what we're doing. It's not about a competition. It's literally about just getting people together, talking about things that matter, you bring up a really good point about being active. So last couple of weeks, talked to Senator Murray and Senator Cantwell's offices. One of my conversations on PBM reform, right? It has to happen. Like these things have to go along the way. We have to find ways to actually bring value to patients. And the other conversation, though, was based on funding to be able to get traditional ways of healing educated inside of our healthcare settings throughout rural and non-rural Washington state. It's got to be both sides of the coin. I feel like oftentimes we do get so focused on this is where we need to go. This is where the bloodstream of our entire system runs through. And that's not the case. And so I really feel like what you were saying with motivational interviewing, I'm also biased and love that there is cultural and motivational interviewing components that are necessary in healthcare to really move the needle. And those are the things we have to be able to work on together. Bruce, any recommendations for folks that are listening into this on the kind of stuff that you'd like them to do in RPH Ally and outside of it to get this needle move like you and I want?
I don't know. Just find any way humanly possible to get involved. There's so many different avenues. Call your state board, call your legislator, tell them, I want to take care of patients, and the work environments are not letting me. Join your state and national associations, but tell them, if you want me to join, I need you to do these things for our profession. Because your money ought to be valuable. So think about, join RPH Ally and get in on the discussion. So anything that people can humanly possibly do. I realize we're all busy, but anything you can do to support our profession. We have got to be a unified voice.
Amen. Yeah, I couldn't have said it better myself. I think for everybody listening, I'm always so thankful for Bruce's time and him advocating for our profession and trying to bring us to a point that we can really impact patient care. If there's any reason why we're growing our PH Ally, and I think all of you are joining, is exactly that same mission. We want to be able to unite each other together, realize that our collective voices can really make a difference and advance the profession to the point where we're really doing what all of us want to do, and that's to truly take care of patients. So please join our PH Ally. Head over. You can find Bruce inside of the peer support channels and several other channels throughout our PH Ally. Get a hold of him on LinkedIn, and let's continue that conversation and really hear, like, what are you guys doing? How do we be able to pull those things together? I know that Bled is doing a ton of things as our VP of advocacy to be able to connect with her too. So we will see you guys over at rphally.com or on the app and continue the conversation there. But Bruce, thank you, my friend, for your time and your support of the profession and always caring so much. It means a lot to me.
Well, thanks for what you're doing.
All right. Everybody have a wonderful rest of the day.
Bye.